We'll be going on to our next session.
Thank you very much.
So much, Claudia. Thank you. So to discuss about is marrow hemophagocytosis necessary for diagnosis of cytokine release syndrome, we have two eminent faculty with us. The first speaker would be Dr. Satish Kumar. I don't think Indian audience needs much introduction to him, but it's still my duty to introduce him. He is the professor of pediatrics at CMC Vellore. He's been trained at Sick Kids Toronto, and he founded the pediatric rheumatology services with Dr. Devashish Danda and CMC Vellore, and he has more than 95 publications. I would request Dr. Satish to take the stage, please. Thank you.
Yeah, thank you. Thank you, Dr. Anand, for kind introduction. And I want to thank Dr. Chandrika for inviting me to deliver this talk. Is my slides are on the...
It's yes. Not full screen, sir.
Yeah, now it's full screen?
No, not yet.
Okay, I will just... okay, I will... Is it now? Yeah.
It's not. Yes,
yeah, it is.
Yes, it is. Okay. Thank you, Chandrika. So the topic given to me was talk about predictive value of bone marrow hemophagocytosis and cytokine release syndrome. So this is my perspective. How good is it hemophagocytosis bone marrow to diagnose cytokine release syndrome? So already much is talked about yesterday by Dr. Ramanan, today by Dr. Fabricio has spoken so much about marrow hemophagocytosis. So I'm going to tell my perspective in the next 10 minutes. So I'll start with the case child, which we have seen last month. So this child I'm following for a long time. So this child I am seen initially when the child is around 2 years of age. This child presented with the classical fever, classical rash, and arthritis typical of systemic JA. So this child was started treatment on prednisolone and methotrexate. Prednisolone was tapered and stopped and continued on methotrexate. The child was doing well, and when the child is around 5 years, she had a severe systemic flare. So this child has received tocilizumab injection for 6 doses. Disease was put under control, was continued on methotrexate. This child was admitted again with pneumonia last year, needing IV antibiotics, and got settled. So this time on January 21st, this child came to us with fever for 3 weeks, worsening of the arthritis, and this time the rash is not predominant. So this child is already on 10 milligram of methotrexate now and prednisolone 5 mg once a day. So on examination, this child was febrile, had a little bit of high heart rate, BPs were in the borderline, but saturating in the room here, has got hepatosplenomegaly, and this child has got arthritis involving elbows, knees, and ankle. So the clinical diagnosis, as any child with systemic JA, comes with fever and worsening of arthritis. We think of disease flare. Because the child is immunocompromised for the last 4 years, which we considered sepsis. And again, we considered MAS, which is called secondary HLH or cytokine release syndrome. So the investigations, what we did on the time of admission, showed anemia, white cell counts of 13,000, which are absolutely normal. Platelets were 2,80,000. ESR is slightly raised, CRP is very high, and liver functions and renal functions are normal, chest X-ray is normal, and blood culture was done and started on antibiotics. And as we consider MAS bar HLH, so this child fibrinogen was low, ferritin was 43,000, and triglycerides were slightly elevated. So what will you do? Will you do a bone marrow for hemophagocytosis to compare, to confirm the diagnosis of HLH or MAS in this child? Or what will you do in your day-to-day practice? So we are talking so much. Dr. Fabricio has talked about HLH, MAS. Nowadays, we are talking about cytokine release syndrome. So this is, I think most of you able to make out. This is Dr. Ramanan in 2003 when he was doing his fellowship in Sick Kids Hospital. He wrote an editorial along with Dr. Schneider about the macrophage activation syndrome. That's a time when rheumatologists started to think about macrophage activation syndromes. He said, what is the name you call HLH or MAS? That time itself, in that paper in 2003 in Journal of Rheumatology, he said that to realize that failure to demonstrate hemophagocytosis does not negate the diagnosis of HLH. And that time itself, they had a plan to do consensus guidelines for diagnosis of MAS, and then it should be validated also. And they said that MAS should be considered as a secondary HLH disorder and should be recognized much. This is the time when I was getting trained there in SickKids. We started to read more about what is called macrophage activation syndrome. So now in 2020, after the COVID has come, the name is slightly changed to cytokine release syndrome. This picture is already shown by so many speakers. So it is not a one disease. It is comprised of different things which lead to the final outcome. So what I say, HLH, MAS, cytokine release syndrome is not the primary diagnosis. It is a final outcome of some disease, which could be, previous talk we heard about genetic mutation. It can be due to immune dysregulation. It can be due to a lot of autoimmune disease, which rheumatologists deal with, and malignancy and lymphoma. And here you can see a lot of infections can also lead to HLH. HLH getting worse and worse lead to cytokine storm. And finally, it lead to multi-organ dysfunction. That's the time when they'll end up with ICU. So when you look into the pathogenesis, so when you say cytokine storm syndrome, in the children with hemophagocytic syndrome, when they become life-threatening hyperinflammatory condition, as I said, it can be due to mutations or it can be due to inflammatory conditions, overactivation of macrophages, leading to hypersecretion of several cytokines, pro-inflammatory cytokines like IL-1, 2, 6, 12, 16, leading to cytokine storm, again stimulating the macrophages, leading to hemophagocytosis, which lead to a typical clinical manifestations. Okay, so Dr. Fabricio already spoken about this criteria. Dr. Hunter yesterday spoke about this criteria. We all know that this is for primary HLH. So we cannot come with this criteria. This criteria is mainly for the primary HLH. Again, in that, we have the hemophagocytosis on the liver, bone marrow, liver, spleen, or lymph nodes. Again, remember, it's very difficult to get. It's not easily available. Like it's not readily, the results will not be readily available, and the child may be sick. And it is modified in 2009. There are also hemophagocytosis there in the criteria, one of the criteria. So it is not like a mandatory criteria to diagnose somebody to have primary HLH. Then these are the 4 different criteria which Dr. Fabricio already spoke about. So we talked about the familial HLH 2004 criteria for primary HLH. In that, hemophagocytosis is there. So if you have 5 out of 8, sensitivity is 100% and specificity is 80%. Then this HS score, which is mainly done in adults. It is not done in pediatrics. It is to differentiate again primary HLH versus macrophage activation syndrome. Again, they're given points to each and every criteria. So what they said is here we can see the hemophagocytosis bone marrow. The score, if it is more than 169, the sensitivity of 93% and specificity of 86%. The other 2 criteria are this MH score, where we don't have hemophagocytosis in the criteria. And recently in 2016, Dr. Fabricio talked about this systemic JA. In children with systemic JA, when you suspect mass, there also we don't have the hemophagocytosis as a criteria. So if anybody who has got ferritin in a child with systemic JA, the ferritin is more than 684 plus 2 parameters, either the platelets or the liver parameter, liver SGOT, SGPT, then we can call them as MAS. So when I looked back to the literature, how good is this hemophagocytosis in the bone marrow? So there are a lot of studies, from old studies to recent studies, which showed that the bone marrow hemophagocytosis, the sensitivity and the specificity is very low. The various studies showed, in this study, they showed that hemophagocytosis sensitivity is 83% and specificity is only 60%. They also said that bone marrow findings of hemophagocytosis should not play a role in the diagnosis of HLH or MAS. They also said that we should go for other biomarkers and then waiting for this bone marrow hemophagocytosis to come. There is a recent paper which is published in 2020 in Critical Care. So they looked into how good is 2 criteria, HLH 2004 criteria and HS score. Again, this is done in the adult ICU setup. What they found out, you can see that hemophagocytosis, the sensitivity specificity is very, very low. So we cannot rely on bone marrow hemophagocytosis alone for diagnosis of HLH. As Dr. Fabricio said, 50% chance. You flip a coin, If you get it, yes. If it's not get it, does not mean the patient does not have HLH. So in the earlier days, it was given so much importance. I think there are a lot of new biomarkers which Dr. Fabrice already spoken about in 2022. So you can see here, these are the newer biomarkers which can be used in the assessing the status of hyperinflammation. And Dr. Fabrice already spoke about IL-18. Very high levels indicate MAS, but not useful for monitoring. He already talked about CXCL9, elevated in most cases of cytokine storm, and it is useful for monitoring. And IL-2RA, CD25, this is their part of the criteria. And very commonly available biomarkers like your CRP, ferritin, very, very important, procalcitonin, ferritin ESR ratio, all can be used for as a biomarker for cytokine release syndrome. So does we do bone marrow again to look whether the hemophagocytosis is gone? So it's very difficult to do, and there is no data to support that. At the follow-up also, I will do bone marrow or other tissue to look for hemophagocytosis. So to summarize, so what I have said so far, the diagnostic performance of hemophagocytosis, it is not sensitive. Often it can be absent initially. Sometimes you may have to keep on doing bone marrow to pick up this hemophagocytosis. Sensitivity may be a range of 50%. Repeat biopsy later may show. Again, yesterday we are talking about this hemophagocytosis can be seen in other infections, even small viral infection. We can have 1 or 2% of hemophagocytosis bone marrow. It can lead to blood transfusions and other autoimmune diseases. So what we do routinely, usually most of the time, children with CRS, the cytokine release syndrome, are sick with bleeding, with liver dysfunction. So bone marrow cannot be done to look for hemophagocytosis. So most of the time we use ferritin as a marker for cytokine release syndrome. This is a picture which Ramanan showed yesterday. If any ferritin more than 10,000, think of HLH, MS, or cytokine release syndrome, and then do all the other investigations to confirm. So what happened to our child? I told him our child had ferritin of 43,000. This child was started on methylprednisolone, 2 milligram per kilogram, because the child is in the ward, not very sick, not in shock, no liver dysfunction. I started on 2 milligram. After 2 days, the ferritin started to come down, but the platelets are still dropping, white cell counts are still dropping. So I added cyclosporine. Following methylprednisolone 2 milligram and cyclosporine, the child started to improve, and the child got discharged on orals, cyclosporine, and steroids. So what is the take-home message? Summarize: cytokine storm is the outcome rather than the final diagnosis. There is no specific criteria for diagnosis of secondary HLS or CRS. Timely diagnosis of HLS is of particular importance. Go by the case by case and use your resources of test correctly. Hemophagocytosis has got very low sensitivity in the diagnosis of CRS. Simple biomarkers of ferritin, CRP low, ESR, and fibrin are useful. And again, the last thing is, don't wait to demonstrate hemophagocytosis, and you should start treatment at the most. Thank you very much for this opportunity.
Satish, thank you for a wonderful talk. Before we go to the next speaker, Dr. Randy Cron has a comment to make that bone marrow analysis is not only used for hemophagocytosis, but can also be used to diagnose leukemia and
yes,
few certain infections when we do a bone marrow culture.
Yeah, more than excluding, not for diagnosing, more for excluding other causes. Agree. Yeah.
To get the other perspective, the hematologist perspective, which these are the people who do the bone marrow examination, we have Dr. Anand Prakash, and it's my proud privilege to introduce Anand Prakash, whom I've known for the last 1.5 decades. When he was a postgraduate student, then he was a colleague of mine in St. John's. Then he went on to do his fellowship in Hemo in Gangaram Hospital, and he also pursued fellowship in pediatric Hemo in Sick Kids, Toronto. And he'll be giving us the hemato-oncological profile, perspective about is bone marrow hemophagocytosis required for diagnosis. Anand, stage is yours. Thank you.
Thanks so much, Dr. Anand, for that kind introduction. I hope my slides are seen on full screen.
Yes, they are.
Okay, thanks so much. Thanks to the team from Rainbow, Dr. Chandrika, Dr. Rakshay. It's been a wonderful learning opportunity. And I think this is one of the few meetings where we've had specialists from intensive care and rheumatology to actually discuss these challenging diagnoses. Let me give you, like Anand said, the pediatric hemonc doctor's perspective, because I think the hemonc team is getting a little, into trouble, because it looks like the rheumatologists and the intensive care teams are very worried. These hemonc people come in, they ask for marrows, they delay diagnosis. And so the question which was put to me is marrow hemophagocytosis necessary for the diagnosis of CRS? And clearly, I think across the board, we will all agree that marrow hemophagocytosis is not necessary for the diagnosis of CRS. But clearly, just like in research, the right question has to be asked. In clinical medicine also, the right test and the right question has to be asked. So if we change the question to, is a bone marrow useful in a patient with suspected HLH? Then I think across the board, we will all say yes, maybe. And if we change the question a little further and say that is a bone marrow mandatory in certain clinical settings of MAS, HLH, CRS, where the diagnosis is still not clear, I think you'll all agree with me that yes, definitely in some cases, marrows definitely are helpful. So I'll take you over the next 10 minutes to look at some of the challenging pediatric hemonc scenarios, the challenges we all face prior to the diagnosis. Once you know, like in Dr. Satish's case, that yes, this is a patient with SLE and they've evolved to MAS, things are kind of straightforward. But when there is a new patient, what are the challenges that a pediatric hemonc doctor faces? And settings where I'll defend my hemonc teams, where they actually ask for a marrow examination. So I think Dr. Fabrizio has warned us that we shouldn't talk about names, and I won't labor on the name game in this presentation. But I think if, like the old Indian fable of the blind men touching the elephant at different parts, if we all open our blinds and speak to each other, we would get the right diagnosis. So CRS is a common pathophysiological pathway, and the hemonc person looks at it from the end of the low blood counts, where already the inflammation has caused hemophagocytosis and low blood counts. And the poor monocytes and macrophages do what they know best. They do phagocytose in the setting of cytokine release. So the end result is what the poor hemonc doctor is faced with a sick child with pancytopenia. So a hemonc doctor would look at CRS not like a rheumatologist. The CRS in the pediatric hemonc settings would clearly be in the setting of chimeric antigen receptor CAR T cell therapy, in bispecific antibody therapy, blinatumomab. And I remember when working as a fellow at Sick Kids, we used to think back at our patients with dengue and say that yes, cytokine release syndrome in CAR T cell patients is kind of a little tricky, but those of us who are trained in Asia and particularly India, where we've looked at a lot of dengue, we tend to pick up vascular fluid leak, which is the basic part of cytokine release in the hemonc settings with CAR T cell therapy. And we tend to pick up these patients relatively quickly and are able to treat them. The other setting in a hemonc setting for CRS would, of course, be post-haploidentical transplantation, and till with the post-transplant cyclophosphamide GVHD prevention. And in that setting, till you give the third and fourth day of cyclophosphamide, you can have a lot of cytokine release when you give haploidentical cells. So in these settings, just like in the rheumatology settings where you already have the diagnosis, we can anticipate cytokine release. So the diagnosis is not a challenge. Therapy can, I admit, still be challenging, and the tocilizumab model has worked well in CRS in the hemonc settings too. But what we are actually faced with is the simple general pediatrician, pediatric intensivist, challenging clinical settings. I've listed some of them: PO with cytopenia and hepatosplenomegaly, PO with lymphadenopathy, sometimes very sick children who come into the ICU already in multi-organ dysfunction, sometimes children who are in the ward who are a little more stable, but who have worrying symptoms of cytopenia, failure to thrive, recurrent infections, some of them who come in with arthritis and truly have a leukemia, some of them who come in with polyserositis and truly have a lymphoma, and of course the immune deficiencies, which come in with recurrent infection and failure to thrive. So looking at it from the primary pediatrician, first presentation hemonc doctor's perspective, it's a little different. So the hemonc setting, of course, there are two questions which are asked to hemonc doctors. Is this HLH? And if so, is this primary and secondary? And it's not always straightforward till the disease process evolves. So we've seen this slide multiple times, and we know now that primary and secondary HLH are not really distinct, ends of spectrums. The distinction is becoming quite blurred because there are heterozygous mutations even in secondary HLH. And once you prove that a certain child has a specific infection and or the child has an underlying autoimmune disease, then things become a little straightforward. Till that happens, it's a little tricky. So yes, all of us have looked at these criteria, and any hemonc doctor worth his salt will tell you that they don't wait for the marrow to show hemophagocytosis in the marrow to start on urgent dexamethasone and etoposide in a child who warrants the treatment. But even recent reviews, this review very recently by both a rheumatologist and a hemonc doctor, show us that how in HLH, a bone marrow aspirate and biopsy may be very, very important early in the course of disease, such that you rule out certain important differentials. Dr. Jan Inge Henter referred to this important consensus recommendations, where he is an author on this, where this is, of course, both for adults and children, and adults have a lot more malignancy associated HLH, where early in the course of disease, as soon as you suspect HLH, you may want to consider doing a marrow. You might even have to look carefully for other focuses like lymph nodes in children and rule out other triggers for secondary HLH. I'll quickly go over in the next couple of minutes a couple of case scenarios which explain how it's difficult when new patients come to us. This 2-month-old with 3 weeks of fever, first child to consanguineous parents, no focus of infection, came in with a large liver and spleen, treated already in the primary pediatric center with multiple broad spectrum antibiotics, came to us with pancytopenia. A lot of infection workup had been done, everything negative, marginally elevated ferritin, definitely elevated triglycerides, and the marrow has not shown hemophagocytosis, right? It just shows a cellular marrow. So what do we do here? Do we rule off the diagnosis of HLH? Of course not. This child was treated as HLH, and later we were able to prove that this was a perforin mutation. So the absence of hemophagocytosis clearly doesn't rule out HLH, and we wouldn't wait for repeat marrows to show it. The second scenario, a 12-year-old who came in with 2 to 3 months of fever, pallor, small generalized lymphadenopathy, a small spleen, came with pancytopenia, again, extensive infection workup negative, imaging workup negative, a marrow is normal. So we got the reference from the primary pediatric team saying, should we start on DEXA plus minus etoposide? The ferritin is high. Would you treat this child as HLH? A lymph node biopsy here showed Hodgkin's lymphoma. And so clearly a precipitous use of DEXA and etoposide would probably have been counterproductive. Standard therapy for Hodgkin's settled all the symptoms. The third scenario, a 12-year-old previously well child, 2 weeks of fever, spleen and splenomegaly of 3 centimeters, has salmonella in the blood. The fever persisted, and the primary care doctor had heard a lot about hemophagocytosis, so he was worried, did a ferritin. It was above the 500 cutoff. The marrow also showed hemophagocytosis, so urgently referred to our center. The CBC with us was normal. The ferritin was trending down. We heard about how the monitoring in serial ferritins is more important than the single value. And this child was well with no organomegaly. So clearly this was just infection-associated hemophagocytosis which spontaneously recovered. We didn't have to treat him with any immunomodulation. So I think this is the most important slide. The salient points are that bone marrow aspirate is definitely not a diagnostic test for HLH. We all agree on that. Presence or absence of hemophagocytosis does not rule in or rule out HLH. It is definitely useful to rule out underlying hematolymphoid malignancy. It does provide supportive evidence in children with recurrent cytopenias and fevers which have settled down and have not gone into extremis. And the test itself lacks sensitivity and specificity, and we've been hearing about that multiple times. So in a setting where the common theme is a relatively rapid need for a quick diagnosis, no single diagnostic test is helpful. So I would fall back on what our undergraduate and postgraduate teachers taught us and say that history and clinical examination is the key. Consanguinity, sibling deaths, previous episodes of so-called sepsis with cytopenias, and uncommon severity of sepsis could all give us clues that there's something wrong with either the immune system, primarily like primary HLH, or a secondary immune deficiency. Malignancy-associated HLH is not common in children. However, we would not want to precipitously start steroids and etoposide in acute leukemias, which would have a lot of mimics to HLH, T cell more than B cell, a lot of lymphomas, anaplastic large cell lymphoma, DLBCL, these would all present with the close mimic. I presented a case of Hodgkin's for you, and other diagnoses like Castleman's and LCH, which would come in with fevers, organomegalies, and we wouldn't want to make an incomplete diagnosis. Always remember that even if we get a viral trigger, let's say we do an EBV or a CMV and it's positive, that doesn't mean that malignancy is ruled out, because viral infections are a common trigger for malignancy-associated HLH. Our own experience, just the last couple of slides, in the last 10 years, in this 25 patients where we excluded all our secondary HLHs, we had a median age of around 7 months. It's interesting to note that in South India, because we have so much consanguinity, we had around 10 Grisselis and 4 Chediak Higashi children. And while literature from abroad would have more numbers of perforin, monk, and syntaxin mutation, probably we are missing those in our part of the world. It's kind of humbling to bring to this audience that while we talk about HLH, only a small proportion of our patients were actually able to get to transplant, just 3 out of the 25. 83% responded to the HLH 2004 protocol. That's very reassuring, even in the developing world. But unless we cure them with transplant, we have a long way to go. So in summary, I would say that just like any other diagnostic test, the bone marrow does have fallacies. The history and clinical examination is important. It's important to do a marrow to rule out other diagnoses. And yes, we know that it's neither sensitive nor specific, but is an essential step to rule out underlying malignancy. So I leave you with this excellent review for any of the trainees in the audience. Thank you so much. Happy to take questions.
Thank you so much, Anand, for a wonderful talk on a hematologist perspective on cytokine release syndrome. As I see that there are not many questions here, and we want to be on time, I would like to thank all the faculty for keeping up the time and finishing on time and answering all our questions. Anand, just stay around. If there are any more questions on the chat box or the Q&A, please answer them. Thank you so much. And I would like to thank from Dr. Farhan and my side, I would like to